Hi, this is Pete Fernbaugh. Welcome to Trinity Talk. Our guest today is Dr. Milton Swaby. He's Medical Director of the Acute Inpatient Rehab Facility over at Trinity East. But Dr. Swaby, your official designation is physiatrist. Could you tell us a little bit about what a physiatrist is?
So physiatrist is a doctor that our basic goal is to try to return people back to as much function as they can, depending on what goes on. So yeah, I like to say that we're like a combination of three kinds of doctors. One, we're like an orthopedic surgeon, but we don't do surgery. Mm-hmm. So understanding the bones and muscles, how they interact, that's one. We're like neurology, but we use our neurology to understand like body function and to drive progress, mm-hmm. right? Understanding like if a stroke is in a certain area, what that means, and now what does that mean in terms of getting people to function better. Mm-hmm. And then internal medicine, we take care of all, like, most of the internal medicine needs in the rehab unit I take care of. So it's a combination of orthopedics, neurology, and internal medicine combined.
That's a unique picture you get of a patient. Now tell us the kind of patients you tend to see who bring all of those elements together.
So I tend to see the most popular patients that I see are stroke patients. Mm-hmm. We have had spinal cord patients. We get a fair amount of traumatic brain injury patients. We get a lot of orthopedic patients like knee and hip replacements, back surgeries. We'll tend to get open heart surgeries that don't go home after 4 or 5 days, that are in the hospital for a month. They get really weak and debilitated. So they will come to the rehab unit. And then we get a whole bunch of just others, right? Mm-hmm. So there are a certain amount of diagnoses that are considered rehab diagnoses, but we end up getting a lot of patients that have functional decline, and they qualify to come based on their functional decline. And then our job is to then try to get them, get their function up, manage their medical issues, and then get them back home.
These are folks whose quality of life has taken a major hit.
Correct.
They can't do what they're used to doing. Right. Some can't even work jobs. Right. And they've been in the system, they've been in the medical system, they've seen lots of different doctors. When they come to you, what is their hope? What are they hoping you can do for them?
Well, I mean, everyone wants to go back home.
Sure.
And everyone wants to improve their quality of life, right? And most people want to get back to what they were doing.
Yeah.
And sometimes that's possible and sometimes that's not.
Yeah.
Even if they can't get back to what they were doing, that doesn't mean that they can't get back to a quality of life that is worthy, redeemable, that is,
Yeah. So, you have to get to know the patient for who they are now, but also who they used to be.
Correct.
Where they want to go.
Right.
That takes a high level of not only medical knowledge, but also emotional intelligence from your part. What do you surmise? What do you look for the second you walk into the room with one of your patients?
Oh, I look at, eye contact, how they respond to just me walking into the room.
Right.
Knowing their diagnosis and what's going on. Sometimes you walk into the room and there's fear. Sometimes you walk into the room and they're like excited because of the potential for making improvements. It just depends, right? And some people are talkers. Some people are very quiet. Mm-hmm. So it just depends on what they have, who they are. And then I think, like I say, my God's gift to me is that, like, being able to connect with all different types of patients where they're at.
Right.
And I used to be a personal trainer, and I think I did that for 13 years in New York City, and I could work with all different kinds of clients back then. And so those kinds of skills, I think, translated very nicely into the inpatient rehab setting.
Right. So you used to be a personal trainer. You just mentioned that for what, 13 years?
13 years in New York City.
How do you think that prepared you for being a physiatrist?
I think it just revealed my ability to connect with different kinds of clients. Like, I could train a 90-year-old lady, a 16-year-old kid, a typical housewife, businessman, musicians, artists, actors, like, and everyone was a little different. So knowing what motivated them, some people needed pushed a certain way. Some people you can't really push, you just are there and that's all they need, you to be there. Some people don't like to do certain things, so you got to figure out ways to get them to do things that they don't like in a way that they do like them. You know, things like that. It was so...
Right, those mind tricks, yeah.
Right, so you just figure out, and the goal is that you want them to train and get better. And I used to have a carrot. I made up these Built by Milt shirts, right? I'm Milton, Swaby. Built by Milt shirts. And clients would do anything to get one of those shirts, but you couldn't buy it. You had to earn it. And clients would see Built by Milt shirts in the Hamptons, in Europe. Like, it's like, who is Milt? And how do I get one of those? Can I buy one? No, you can't buy one, you have to earn it. So you come up with a lot of like different ways of
making it a legit prize, making a reward for what they've accomplished.
A reward, so yeah.
And so obviously you were trying to help them achieve a higher quality of life. You're doing the same thing here. So we all use the same words, you know, but we don't always mean the same thing. Right. So what is your definition of quality of life? How would you define it?
So quality of life, I mean, it's different for everyone, right? Somebody's quality of life might be that they want to be able to get down and play with their grandkids. Another person's quality of life is like they just want to go back to their regular job, right? Other quality of life is, okay, they were a runner, or they were, they're a marksman, and they want to get back to doing that. It's what people enjoy doing and what gives meaning to them, right? And so my quality of life would be different than yours, right? And so so being able to just, in the rehab unit, patients stay for a while, right? So it's like you have a chance to interact with them and get to know kind of what they want. And then in my clinic, I don't see 20, 30 patients in an afternoon. A busy clinic for me will be 5 or 6 or 7 patients. So then that means that they come in and then we have time to interact and talk about different things.
There's a lot you do that goes against the grain of some medical thinking now.
That I do, yes.
Yeah. So I know everyone's story is different. What's the commonality, though, between the patients you see, among the patients you see? Is there an underlying factor that you end up addressing with just about all of them?
I think everyone, they were one way and now they're a different way.
Yeah.
And and often there's no way of going back to exactly the way you were, right?
Yeah.
So something happened, right? And now here you are, right? And so it could be a patient that's a stroke, right? Okay, they weren't a stroke before, now they're a stroke. It could be an amputee. It could be a Parkinson's patient. It could be an MS patient. It could be someone that had open heart surgery and now they're like, oh my goodness, I had this major surgery. Right. I can't do anything now because my heart is so fragile. So I think that's it. It's like everyone was one way and now they're this different way. And it's about getting them to maximize what that way is. Like, some will be able to go back, but some won't. And sometimes going back, like, they have to figure out, okay, well, what's important to me? I'm not gonna get to exact, but I want to be able to still play with my grandkids, still go to a baseball game, still work at my job, still, with the new you.
So there's a degree of acceptance that they have to achieve as part of their treatment plan with you.
Yeah.
So you oftentimes, to a degree, have to play therapist with them too.
Oh yeah.
Yeah.
Yeah, there's a lot of psych in so maybe I should add psych to, neurology, ortho, internal medicine, and psych. Yeah,
it's really the whole person that you're,
Yeah.
The person who can't go back to how they used to be.
Yeah.
You mentioned, I love the way rather than saying acceptance, you said maximize who they are now. So the person who can't go back to what they once were, what are some of the ways you approach that, where you help them to maximize who they are now, where they are now?
I think it just boils down to finding out, like, what is the core? Like, what is it that they need to be able to do or they want to do? Like I had a guy that was a really bad, stroke patient that he's an accountant and he wanted to be able to go back and do his accounting. And though his stroke was severe, his brain was fine. He had a great wife, was also part of his business, and he went back to accounting. That's what he wanted to do. So, someone that's a spinal cord injury, that's a different kind of for them a spinal cord injury, what's their goal? They want to be able to bowel and bladder themselves.
Right.
Like it becomes like you think, oh, if you had to give them one thing to do, like if I could fix one thing in certain kinds of spinal cord injuries, you would think they would pick, oh, I want to be able to walk again, or no, but you can only pick one thing. They would pick bowel and bladder control.
Yeah. Because you take that for granted.
You take that so for granted.
Yeah.
Yeah, they would take bowel. Oh no, I'm fine with this. I'll just take bowel and bladder control. I can go into the bathroom and take care of my business.
So a degree of dignity that you're restoring to them as well.
Right.
You also are, I don't know if you'd call yourself an expert, but I'm sure compared to all of us you are, in metabolic medicine. So tell us a little bit about metabolic medicine.
That's one of those things where I could say that I'm not only like, I'm also a client in terms of I've had metabolic issues. I was pre-diabetic, hypertensive, 30, 40 pounds overweight. And I've been able to reverse all that by diving into like why we're sick, as opposed to just, taking a pill for my insulin resistance and taking a pill for my hypertension and just understanding physiology and then being able to reverse that. So instead of like, I'm hypertensive, here's a pill, it's like I'm hypertensive. Let's look at the underlying things. Let's fix those, and now I don't need hypertensive medicines.
Yeah.
So, or the same thing with diabetes. So I ended up doing a very deep dive. It took a while. I had to find the doctors that were like presenting the data. So the data is out there if you look, but there's so much data that is poor. And then you end up realizing, like when you look at certain guidelines, they're made by consensus, not even like research. It's just like they get a bunch of experts together and they decide that this is what it should be.
We think that's the truth.
We think that this is it.
Yeah.
So all their biases get put into that. So it's not based on research, right?
Yeah.
So you have that, and you have then research studies that are really poor studies.
Yeah.
Like these epidemiological studies sometimes are very, where they give somebody a questionnaire and they ask them a bunch of questions like, how many pounds of grapes do you eat in a year? And, how much, like these kind of questions and then they'll find some sort of association like red meat and heart disease and red meat and colon cancer. But they don't take into account that, so the people that are eating red meat are probably not following with their doctors. They're smoking, they're drinking, they're not exercising.
The other factors.
The other factors.
Yeah. And a very specialized physician, that's challenging for the rest of us who are just left to Google to figure.
Right. There's a lot of stuff when you Google that is the opposite of what, and so unless you know how to recognize, know the data, I went to Georgetown, they taught us how to assess studies, right?
Yeah.
So I pulled out the studies. So I look for studies. If I'm watching someone, I want them to show me the studies, and then I go find the studies myself and then go over them. So I did a really deep dive. When I made that change, when I lost the 30 pounds and it was, I don't know, about a year of just like, I would go home and I would just like, okay, this is not good. This is good. There's the research. And then I started going to conferences and meeting some of these same docs.
Yeah.
In these conferences.
And how did that change your perspective?
Oh,
Yeah.
Well, it was great because they were like, now I could ask them directly. And the fact that they were at these kind of conferences meant that, okay, this is not just, a thing that they're doing to make money. They're at these conferences and they're giving these great talks, and then you can ask questions and
they're passionate.
Ooh, yeah, you could see. And the thing is, all these docs that are working with patients, you can see that we all say the same thing. It's like we're reversing the stuff on patients. Like when they come to us, it's like we're able to change the trajectory of their illness in a way that is not done typically. So
what you're telling patients is that it's not a reliance on that pill box for the rest of their lives.
Right.
For many of them, you can actually help them get beyond medication, or at least put the medication in perspective.
In perspective. I mean, and some people will need I'm not poo-pooing medications. I'm just saying, if you can get to the root cause, if you're on 20 pills and you can get down to 5 pills, but that's a win, right?
Absolutely.
If you're on, 20 pills and get down to no pills, that's a win. If you can, if you're overweight and you're able to then, decrease your joint pain by just losing weight in a way that you're not starving yourself, you're feeling like you're satiated when you eat, and it's like, wow, I'm eating all this stuff and I'm losing weight. That's not typical. Normally you got to starve yourself to lose weight, and then it comes right back, right? It's a different kind of mindset when you're like controlling what you eat. And then, part of what I do is also intermittent fasting. So that means you're controlling when you don't eat, but when you eat till you're full, but you eat the right thing. So then the body learns to go, okay, well, he's not eating, but when he eats, I'm totally satiated. So then it teaches the body how to burn its own fat for fuel. And that's what happens. And once you can get your body to realize that, okay, I have this fuel source that it's abundant. Even the skinniest guy has enough fuel to run 10 marathons.
That's remarkable.
In their fat.
That is remarkable.
Right.
Yeah.
And once your body learns to do that, then you have unlimited fuel source.
But we are so conditioned to believe that fat is bad.
Right. Fat doesn't make you fat.
Right.
It's carbs that make you fat.
Right.
So it's not fat. So we believe that we're eating fat, so everything is low fat. But you could just look at the data. You don't have to take my word for it. Since we've been eating low fat, we've gotten fatter.
We're talking since like the 1970s.
70s.
Yeah.
Right. And so when you take fat out of food, which has a lot of flavor, then you have to put something else in to get more flavor. And the kind of stuff that's put in are more sugars and more, seed oils and like all this other stuff.
Do you get personally excited when you see, like you so beautifully described how not everybody lands at the same place.
Right.
But that doesn't mean it's not a victory.
Right, exactly.
And sometimes these one-size-fits-all diet and workout programs make you think you have to be one certain way, and that's your victory. As long as if you look like everybody. But no, it's a little victories along the way.
Right.
So how excited do you get?
Oh my goodness, it's totally like I love it.
Yeah.
Yeah, I feel like this is fun, and I feel like a real doctor. I feel like I'm like, like helping. Like this is why we went to medical school, right? We didn't go to medical school to just like prescribe meds, right? We went to medical school to try to reverse people's health, to help people live better, live longer, handle hardships that have come with their health. That's why we went to medical school. And just this that's why I loved rehab medicine though, because rehab medicine for me, it was like, okay, I'm not able to reverse all this. That's why I didn't do internal medicine. So rehab medicine, okay, yeah, bad things have happened, but I'm able to take that bad and then help them like make the best of it, or give them a life, or
or bounce back even more than they themselves expected they could bounce back.
Right, exactly. So I mean, people that come in an amputee and then I get them a leg, I work with a prosthetic person and they're walking and they can't believe they're walking.
I hope you write a book someday of all the stories. Is there anything else, as we wrap this up, is there anything else you'd like our viewers to know about what you do, both from a rehab perspective and then also metabolic medicine?
I think, like in terms of rehab, I often think that a lot of people think they know what a rehab patient is. They, like someone, I could see a stroke that is like barely walking, barely talking, and someone that's not a rehab doctor will look at that person and say, well, they'll never be able to do 3 hours of therapy a day because that's the requirement. But I would come and look at that patient. I know I'm going to get 4 weeks with that patient, so I'd be willing to take that patient. and know that I'm going to get the time that they might walk out, right? But the thing is, sometimes I don't even get a chance to get at that patient because somebody else will make a decision for me. It's a challenge to when other people can make that decision, and then it affects like how many patients we get and all that kind of stuff. So, I mean, that's one thing. And the other thing, in terms of just metabolically, I just want people to just be aware of, like, sometimes all you need is a little bit of awareness and of the foods that you're eating, and just realize that, okay, so you mean what I'm putting in my mouth directly impacts my health, and if I could just change that, you know, in a way that works for me, that I can like, you know, go back to your high school. I went back to my high school weight, you know, my high school pant size, you know, and feel 10 years younger.
Many of us can only hope.
Right. So,
but you're saying it's possible.
Oh, absolutely.
It could very well be possible.
It's absolutely, it's possible for everyone to, right?
And what I love is that you're living proof of it. So you're not.
Here it is.
That's right. Thank you so much for joining us today. We hope to have you on again.
Okay.
You're just a wealth of information.
Okay.
So thank you so much.
All right.
Absolutely.
All right.
And thank you for tuning in to Trinity Talk. We hope you join us again next time.